Hello everyone. I am Dr. Prachi Jain. I am Senior Consultant and Head of Division of Pediatric Oncology and Hematology at Max Institute of Cancer Care, Max Hospital, Vaishali and Patparganj in Delhi, NCR.
So ma'am, kindly tell about your background and motivation. And ma'am, can you share a bit about your journey into oncology? What inspired you to choose this specialty?
So while I was doing my MBBS, I was really inspired by my head of the Department of Pediatrics. And because of her, actually, I wanted to take up pediatrics as my future profession. And by God's grace, I even got a good rank in my MD exams. During my internship, I also did a pediatric advanced life support course to actually know whether I would be able to fulfill the needs for pediatrics or not. And after getting a good marks in MD entrance exam, I chose pediatrics as a specialty. And I did my MD Pediatrics from UCMS Delhi, where I had the privilege of working under Dr. Sunil Gombar, who used to head the unit and the division of pediatric oncology there. And that is how I developed my interest into pediatric oncology.
As far as the patient empowerment and public awareness is concerned, how do you engage patients in their treatment decisions? Do you have any advice to help them feel more empowered in their care?
So, coming to a diagnosis of cancer for a child is very disheartening for the parents. They need a lot of support. And this is the bad news which a doctor has to break to them. So my principle is I never tell them in the first go that your child has cancer. We always tell them the provisional diagnosis that we have in mind based on the reports that are available, and gradually we tell the parents about the diagnosis. I make sure that we discuss the diagnosis in details, the treatment plan for their child, various long-term and short-term complications that may happen during therapy, and the overall prognosis. I always start with telling them that most of the children with this disease, cancer, are going to get cured and lead a normal life, which is a truth in today's world. Also, we have a lot of parent support group activities, social engagements that we engage children and parents into to help them go through this difficult journey. We also give them a diary which contains basic information about the symptoms, the problems that can happen during therapy, and what needs to be done when they encounter with that. We have a background of good social support team, a play therapy area, a dedicated ward for pediatric oncology patients, wherein children feel more comfortable and secured while they are on therapy.
What are your key strategies for preventing, identifying, and managing hypersensitivity reaction due to E. coli derived asparaginase?
Asparaginase has a critical role in treatment of children with acute lymphoblastic leukemia, which is a type of blood cancer. This molecule is derived from a bacteria called E. coli and is known to have hypersensitivity reactions. We don't really do anything to prevent these hypersensitivity reactions because it is known that even if there is subclinical hypersensitivity, again, this drug is going to be destroyed inside the body. So we do not really want to hide the symptoms of hypersensitivity. Whenever we give this medicine, that is L-asparaginase in our unit, we always keep hydrocortisone and diphenhydramine injections bedside so that if the child has any such reaction, we stop the drug infusion immediately and treat the child for hypersensitivity. We also have the crash cart ready because sometimes the hypersensitivity reactions can be very, very severe. So while this drug is on flow, all our nurses and doctors in the unit are on high alert while giving this medication.
Ma'am, when evaluating the therapeutic response to Erwinase in patients with acute lymphoblastic leukemia, which clinical and biochemical markers do you monitor?
So there are trough levels available for Erwinase or asparaginase drug for therapeutic drug monitoring. So there are therapeutic drug monitoring levels which are available for this drug molecule, but these are not readily available and are actually used in research setting. So in practice, we are not monitoring the Erwinase drug levels, neither are we monitoring E. coli asparaginase drug levels. The treatment of ALL includes multiple chemotherapeutic agents. The success of therapy depends on all the agents given timely. So it's very difficult to say that one particular drug has done the benefit. It actually has to be studied in clinical trials. So proving the efficacy of the drug based on one or two patients is not possible.
Ma'am, now the case studies, if you can discuss.
I have used injection Erwinase, which is Erwinia asparaginase, in 2 of my pediatric patients with acute lymphoblastic leukemia. One child was a 14-year-old boy who developed drug reaction to pegylated asparaginase while he was on reinduction chemotherapy. As soon as he developed the reaction, we stopped the drug infusion, we stabilized the child, we gave him anti-allergic medications, and he was stabilized. And we discussed with the family the option of Erwinase. The family wanted to go ahead with it. This drug Erwinase is currently not available in India and has to be imported from outside. So we contacted the companies which help us procuring such drugs, and the child was lucky, I should say, that one of the vendors had a few vials available, so we could start his therapy within 4 to 5 days of the drug reaction that he had. Injection Erwinase was given to this child as 6 doses every alternate day, and child tolerated all the infusions very well. So the second child for whom we used Erwinase was a 6-year-old boy, a high-risk ALL, and was being treated as per the icicle high-risk arm. He was getting his dose of pegylated asparaginase during the consolidation phase, the last dose of that phase, and towards the end of the drug infusion, he developed reaction. We again stopped the drug infusion, stabilized the child, and next dose of asparaginase had to be used in the delayed intensification. So we had about 2 months to prepare the family for this and for them to arrange the drug. When the child entered the delayed intensification phase, we already had the drug Erwinase, and we could give the drug to the child on alternate day basis. One of the limitations this time was that this drug molecule is available as a packing of 5 ampoules in one pack, while the recommended doses is 6 doses every alternate day. For this child, to deliver 6 doses, we would have to buy 10 ampoules instead. So, after discussing with the family, we decided to give only 5 doses every alternate day. The first child is almost 2 years post completion of Erwinase therapy, and the second child is almost 8 months post Erwinase completion therapy, and both these children are doing extremely well. The drug molecule Erwinase, like its counterpart pegylated asparaginase, needs to be strictly maintained in cold chain. In my experience, Erwinase is quite well tolerated given as an infusion under monitoring. My experience with this drug has been good so far. Thank you.